Thank you so much for that introduction. It is a tricky topic, and I just want to start by saying that this is really the work of Julie Barnett, who's a quality of care advisor based in Geneva, who unfortunately couldn't be here today. So what are patient safety incidents? So these are events relating to the medical management of a patient or healthcare circumstance that could have resulted or did result in unnecessary harm. And I think we're probably most aware about harmful incidents, but this really is just the tip of the iceberg. There are also no harm incidents and near-miss incidents, which contribute quite significantly to patient care and also have many lessons which we could learn from. To give you an example of, if you're unclear about the definition, so no harm events are incidents that actually do reach the patient but don't cause harm. So an example might be oxygen tubing being disconnected, but the patient's saturation is being maintained. Whereas a near miss is an event which never actually reached a patient and was caught beforehand. So an example I would give you is a prescription by a doctor, perhaps an insulin prescription that was 10 times what it should have been, but it was detected by a nurse in advance and corrected. So as you can imagine, many of the no harm and near miss incidents never really get recognized or reported, but are as important as harmful incidents. I wonder how many people in the room who work for MSF have ever read the MSF Charter? Probably not many. Oh, there are a few hands. Okay, I'm impressed. I have to admit I haven't. There are actually, so it does mention medical ethics. So we do have a duty to provide care without causing harm to our patients. We are also accountable to our beneficiaries. So these are the patients, the families, the communities that we serve, and also to our donors who fund our activities. But ultimately, the objective of PSI reporting is to ensure that we don't cause harm to our patients or future harm to our patients. I'll just move through. So these slides are actually the old slides. I had some updated ones. Objectives of PSI reporting, so it's obviously to discuss the event that's happened, to analyze what's happened, and come up with some action plans, which we can implement not only in the project that we are in, but also for all projects within OCG. We are all responsible, and in effect, in projects, it's not just the medical activity managers or the medical team leaders who are doing the reporting. It can be the nurses, the medical doctors, locally hired staff, or international medical staff. And of course, we want to do it as soon as possible so that we can identify any immediate risks to the patients, but it also is useful to do it a few days later, a week later, a month later, because we can learn lessons which we can then apply to other patients going forward in future. So how do we report PSIs? We have a patient safety incident reporting form. So this is comprised of a few sections. The first section is where we write down a chronology of the facts as they happened, leading up to the incident. Sometimes we involve HR with this because they can assist with advising on open questions that can be asked in a non-judgmental way. But HR are never actually present during the information gathering sessions, and everything is confidential and anonymized. The next part of the patient safety form looks at a root cause analysis. So it has a template of a fishbone assessment, and this is to guide the teams in thinking about the contributing factors, so whether they are grouped by communication issues, equipment issues, or things relating to the environment where the incident happened. And then there is an action plan grid where you can detail what you think you will focus on, what resources you might need, who needs to be involved, and what kind of metrics and indicators you'll use. Once this form has been completed, it's sent to the quality advisor in HQ, and then discussions are had at HQ level, and then with the coordination, the mission, and the project. And then the conclusions are shared with patients and families. Of course, there are some certain instances where perhaps the incident has an impact on the security of the project or members of staff, and so there may be some deviation from that. There may be certain aspects which are withheld, and there are sometimes discussions with the legal team in the mission or in the HQ, depending on the severity of the incident. I think what's often missed is the second point, support to colleagues. So these are what we sometimes call the second victim. You can imagine if you're a nurse or doctor involved in a patient safety incident where harm has happened to your patient, it can have quite a significant effect on you and your future work. So we need to remember to support those people as well, not just the patients and their families. Looking at patient safety incidents by country, so these are the figures for 2024, and you can see that there were 15 countries that reported incidents in that year. To give you some background, we were working in 34 countries in that year, so about half of the countries reported incidents. And I think what's worth noting is the number of incidents reported doesn't necessarily correspond to the number of patients being seen in that country, and it's much more a reflection of the culture of reporting incidents and the training that some of the team members might have had in those countries. So in terms of PSI type, at least 75% of all the reported PSIs resulted in death or severe harm. So the definition of severe harm that we're using is long-term disability, anyone which required resuscitation or intensive care, and long-lasting kind of permanent disability. So it's quite significant numbers, but there is obviously some bias in that the reporting of moderate and mild and non-harmful incidents probably doesn't happen as much as it should do. And you can see there was only one near-miss event reported, and that's likely for that very reason, that they don't really see it as something that needs to be investigated and passed up the communication chain. I can say that for this year in 2025, there have been 7 near misses, so there's a slight improvement from that perspective. In terms of location, so most of the pediatric patients who were involved were seen in pediatric wards. These numbers are for all patients, including adults. The next most common location for pediatric PSIs was in the maternity ward, followed by the inpatient therapeutic feeding center. I think what is not captured in this graph that I can tell you is that there were no pediatric patient incidents reported in OPD or in mobile OPD clinics, which is interesting because we probably see the most number of pediatric patients in those locations. And I think this is just part and parcel of PSIs being considered to be a secondary healthcare kind of incident and not something that we often see in OPDs, but the reality is obviously far removed from that. In terms of numbers, so 160 reports in 2024, and 55% of them were in children under the age of 15. 51% were under 5 years of age. And I'm going to move to talk about never events. So these are events that are preventable and should never have happened under our care. There were 9 in 2024. 4 of them were forgotten tourniquets, and I'll go into that in a bit more detail later on. And 4 were medical falls from beds, all in pediatric cases. So these were children under 1 who were sleeping in adult beds without side rails, and there were varying degrees of consequences in terms of problems afterwards. There was 1 ABO incompatible blood transfusion where a cross-match was not done before the transfusion. And the only other type that is not listed here as being reported are retained surgical instruments after an operation. So there weren't any of those reported in 2024. If you remember from previous slide, there were 160 reports, and there were only 88 quality improvement projects sent to HQ. So clearly an area that we can improve on. Ideally, they should all have quality improvement projects. The key themes that were shared amongst them were training, so this could be improving training around blood transfusion, communication tools, introducing SBAR for patient handover. Patient flow improvement was a very common one, knowing that the sickest patients sometimes weren't in the correct areas. They hadn't been moved to the ICU, they were still in the observation area, and there weren't sufficient staff to look after them. And then health promotion activities surrounding this as well. So I just wanted to delve a little bit more about tourniquet injuries. So there was a project that had a case of an under 1-year-old infant who had a tourniquet applied for blood sampling for a blood test. Unfortunately, it was forgotten for several hours, and this resulted in ischemia in the limb and eventually a partial amputation. And this is not an isolated incident. There were also 3 other very similar incidents in other countries and other missions. But the team in the first project was very proactive in trying to come up with a solution and to come up with ideas to prevent this from happening. So one of the main things identified in terms of preventing it was that nurses were using gloves as tourniquets, and they weren't using properly designed tourniquets. So we made sure that this is now included in their pharmacy orders. The reason is they're brightly colored, they're easy to see. Gloves, they're generally quite thin and can be easily missed, particularly when you start getting edema around the area. reinforcing nursing care around this. And I think one of the big changes we've had is having a checklist of what you bring to the bedside when you're doing a procedure. If you bring a tourniquet, make sure you take a tourniquet back afterwards. And I think that's a very simple thing to institute. Another thing in terms of detection was undressing children. So a lot of these incidents happened during the relative cold periods in our countries, where the children are overdressed. So they would push the sleeve up, apply a tourniquet, the sleeve would then fall back down, obscuring the tourniquet, so no one was aware it was still in place. So making sure that the area that you're applying a tourniquet to is completely bare, so that it's obvious it's still in place, is an easy thing to do. Another point was that a few of these patients were actually crying, obviously because of the pain of having a tourniquet applied. Unfortunately, when this was raised by the parents to the nurses, it was dismissed as a tantrum. And so if a proper pain assessment had been done using an age-appropriate pain scale, then we might have detected this and been able to remove it. And I think we have to remember that as an adult, if we had a tourniquet applied to us, we would just remove it ourselves. But when you're a young baby, you can't do it. All you can do is cry. So reinforcing the voice of parents, I think, is key. And in terms of the recovery and recuperation, it's important to make sure you are transparent, compassionate to the family, and give a full apology. And one thing that we have done from now is to create we've created an alert which went out to all of the missions to really highlight this as a problem. And these are the key take-home messages I wanted to share with you. So thank you for your time.